Hello, and welcome to this PCR webinar, DCB Digital Crosstalk number 2. This is part of a DCB webinar series. We've already covered drug-coated balloons as a first choice for patients with de novo lesions with Xavier Escanet and Bruno Scheller. We have talked about in-stent restenosis, of course, the role of DCB today with Fernando Alfonso and Azim Latib. And now, today, what we're doing is going further and look into practice patterns. The number 1 and 2 are available online, and so will be these series of today. So this is a series that is supported by an unrestricted grant from Concept Medical. What do we do today? This is our faculty. I'm Andreas Baumbach from London. I'm in the Paris studio. We've got Professor Bernardo Cortese here. He's now in Cleveland, Ohio, and he'll be live remote. Dr. Rajneesh Kapoor from Gurgaon in India, and Dr. Maud Ali Rosli from Kuala Lumpur in Malaysia. So for Bernardo, it's breakfast television. For the others, it's evening news. And we have visitors, audience from China already and Uzbekistan, I have seen on the chat. You can participate. We don't have polls today, but you can ask any questions or give any comments or simple greetings through the chat, and we will try and comment and answer these questions. So today, as I said, we want to review practice patterns because I'm sure you have heard a lot about DCBs in the recent month and year. We had a change in guidelines, we had a lot of discussions and new evidence coming along, but what do the real power users do with these balloons? How does their practice differ in the various parts of the world? And how are we treating diffuse disease, diabetes, and how are we treating various clinical scenarios? That's the discussion point today, and we'll have plenty of examples. So we'll look through the practice in Malaysia, Maud Ali Rosli, and I can already tell you we had England and Italy this morning, and there in dedicated centers they do about 30% of their cases with DCBs. Rosli is going up to 70%, and that's an amazing number, and he'll show you what can be done there. Rajneesh Kapoor will talk about India, Bernardo Cortese as insight in the US and what's coming in studies, and then we'll discuss question and answers. We have a case in point at the end before we close today's edition and the whole series with that. That said, I hand over to my friend Rosli. Tell us what you actually do in Malaysia.
Thank you very much, Andres. It's really a pleasure to be on board for this session. Okay, so DCB practice in Malaysia. I just want to share this. I was really much younger back then, nearly 2 decades ago. The first drug-coated balloon, which is a sequence please, was officially launched worldwide commercially in Malaysia. So that was in 2008. In fact, we were involved in a PEPCAT trial, PEPCAT-4 trial, utilizing this device in centers in Malaysia and Thailand, and we published that, and that was our way of being involved in this technology. Now, when we look at the number of cases that was done with this procedure, we find that if you look at this data, this is coming from the National Cardiovascular Registry. And we see that in this case, the number of BMS drops over the number of years, the DS came up, but the number of cases doing or utilizing DCB has risen over the number of years. It is not the same as with DS, where it was exponentially high, but this is a slow increase in the numbers, so much so that in 2022, 31.5% of the devices were actually DCB. So a slow rise, but a definite rise. what we find that at least over the last 2 years, that was published in 2021, 2022, and the length of lesion was slightly longer in 2022 as compared to 2021. In fact, the vessel size was a bit larger than in 2021. So it just tells us that it appears that we are using it for more complex lesion, long lesions, and the size is slightly more. And that may be indicative that we are actually using it in more de novo lesions, which are larger vessels. So that's a trend that we see over time. Now, with regards to the way that is practiced in Malaysia, obviously, a lot more interventionalists are using DS. Not many are using like a high number of DS. Most times they're not. They're using maybe about 5 to 10%. But what is changing is that we see the teaching institutions in Malaysia are using more DCBs. Some, and these are centers which are doing more than 1,000. And we find that the number of DCBs are rising, so much so that the trainees, the young interventionalists, when they go out and practice on their own, they're now using more DCBs. And I believe that is the reason we are seeing a rising trend in the usage. And I believe there is going to be more over time. And okay, this is our own procedure and statistics in our center. We are probably the largest private center in Malaysia, probably doing 1,400 cases this year. And what we find, at least in our own center, we find that the use of drug-eluting stents by itself over the years has slightly trending downwards. For nearly 50%, now it's only about 42%. The use of DCB pure, which is only DCB alone, has been about 9 to 10%, and that has been quite stable. But there is a rise in the hybrid procedure. It means that the patients who receive stents and DCBs are now increasing in number, and it's around 45 to 50%. As a personal basis, as Andres mentioned, I do personally about 70% of my patients will receive a DCB, and 30% will just receive stents. So at least the practice on a personal note has risen over a number of years. And okay, if I were to be able to move this slide, these are the cardiovascular risk as seen from the National Cardiovascular Registry. We find that the 3 top risk factors, hypertension, dyslipidemia, and diabetes, are rather high. And if you look at the diabetes itself, it's about 45% of patients are actually diabetics undergoing PCI. So that's a fairly large number of patients. And what we find, it's not uncommon to see that these patients tend to be much younger. They have multi-vessel disease. They are long, diffuse disease, small vessel caliber. And quite a number of them are calcified lesions. And these are the cases that we try not to stent. And the young ones especially are being treated and being taught to perform DCB in trying to reduce the amount of metal that is used, and therefore hoping that it will reduce stent failure in the future, maintaining blood side branch patency, and especially in calcified lesions, even though the data is not really strong there yet, but one doesn't want to use DCB or rather stents as much as possible because they tend to be long diffuse lesions. The risk of complications is much higher. And when you have a vessel which is not well expanded, you are inclined not to put in a stent and trying to avoid stent under expansion. So those are some of the reasons why we tend to use drug-coated balloon, and we see that the numbers are increasing. I think we are always reminded, and I think this has an important slide, and coming from a lot of guidelines, and this is just one guideline, the international consensus guideline, showing that the importance of optimal lesion preparation. It's very important to have a lesion which is well prepared before you consider DCB. Lesions need to be prepared well, and you need to consider sometimes specialty balloons, even a atherectomy device, and then you see the results that you obtain. If it's an acceptable result, it means to say that there is no no flow limiting dissection, there's no increase or large residual stenosis, and the flow is good. Then we should use you can consider using DCB. Otherwise, you should consider using DES. Now, the other thing that is just a picture that I just want to put up, showing a number of the people like Bruno Shell on the right side, Thomas, and even Antonio Colombo, who's already now currently interested in using DCB and not just 10 patients. So that is actually current situation in Malaysia, but I believe that DCB is an attractive concept of treating lesions and leaving nothing behind. Thank you very much, Andres.
Excellent. Thank you very much. Before we move on, I've got one question, and I think that's just specific to your situation, and that is reimbursement. It's not usually the first thing that comes to mind, but because we discussed it just before the webinar, just tell us the differential between a drug-eluting stent and a balloon, and a drug-coated balloon.
Yeah, for DS, they are still cheaper than DCBs. A DS would probably cost about 800 euros, and for a DCB, perhaps about 850 euros. So it is still cheaper with DS, but we hope that with the attractiveness of trying to prevent stent failure in the future, this will help to, at least improve patients' situation in the long term. So, in reimbursement-wise, in the government center, they are paid by the government. In a private center like ours, obviously, insurance or patients will have to self-pay.
Yeah. The reason I bring it up is because it might explain the differential use in Europe. The different price, the difference in prices is much larger, and hence a hesitation maybe to use drug-coated balloons to the extent that you employ them clinically. We move on. We move to India, where we've got Dr. Kapoor, who will tell us a little bit about his practice there, and with a focus on diabetes and diffuse disease, maybe.
Well, thank you, Andreas, and good afternoon to everybody. It's a privilege to be part of this forum, which is actually looking at best practices, how we can actually do the best practices all over the world. So hi to Dr. Rosalie and hi to Dr. Bernardo. So my job is to take you through to a practice in India as regards the Indian perspective. No, undoubtedly, India is a diabetic capital of the world, and we have huge numbers of diabetic patients and diffuse disease. So definitely, in our practice, if we talk of drug-coated balloons, again, the numbers have gone up. The usage is increasing over last 10 years or so, but not to the extent which Dr. Rosalie was pointing in Malaysia. So I would still suggest that about 2-3 years back, we were just about 5% of our procedures where we were using drug-coated balloons. So now probably that 5% we have moved to 15% of total of our procedures. And another big reason which I believe that why this is happening, the coronary imaging actually penetrated into India, is now further mushrooming in all the cath labs across India. But I believe as for now, it's 15% of cath labs which are equipped with coronary imaging, and they have either IVUS or OCT with them. And that has made a very good, important, key point in decision making, where DCB is going to be better, especially in de novo lesions, or we stick to the stents. So if we talk of diabetes, as I mentioned, diabetes India is a diabetic capital. So there are very big limitations of current deaths in diabetes. So if we talk of that, we know that in diabetics, the instant restenosis are still higher as compared to non-diabetics, and the reasons could be the delayed vessel healing due to slow endothelialization, the increased inflammatory responses, and that leads to either edge restenosis or focal restenosis or diffuse restenosis also. We have actually confronted all these patterns of restenosis in diabetic patients. Usually the Indian coronary arteries are smaller as compared to the Western world. So if you are talking of 3 to 3.5 millimeter vessels, we are talking of 2.5 millimeter vessels in majority of our patients. And obviously in diabetics, they are also prone for more acute or subacute or late stent thrombosis. And these things lead us to think that if we can deliver a metal-less PCI in such patients, that's going to be a boon for all these patients. And okay, so yeah. So overview, as I mentioned, the number of diabetic patients is very extensive in India, and we know that all over the world, diabetes remains the main Achilles heel once we talk of outcomes in interventional procedures. I'm not going into this detail. So I'm not tuned to use okay. So this is our data. So based on once I got this talk, I extracted the last year data in our institute. This is my numbers. There are other operators. I think it gets tripled if we talk of the total numbers. So in last year, total number of DCB usage is almost 134. And out of all the patients of all the PCI numbers, and hybrid usage was almost 30-40%, and only DCB usage was higher. If we talk of indications where we have actually utilized this DCB in our patients, majority still has been in-stent restenotic patients. So still the practice is a little bit more conventional, but it is now expanding towards other indications. One thing to mention here, if we talk of in-stent restenosis, there were many patients who had already received 2 stents. There were 2 layers of stents, and now they have again presented restenosis. So obviously, any new stent is totally, out of our thinking, out of our decision making. So it's clear-cut a patient for a DCB usage. And there have been many patients with a single layer of stent with in-stent restenosis. The small vessels, again, there were many patients with the small vessels, almost 20%. And there are few patients with a side branch ostial involvement, where after doing a kissing, we have used a drug-coated balloon to make the patency of that ostial side branch more, durable in those procedures. Now, de novo is, I think, we have been talking, we want to more talk about de novo lesions. So it is still in infancy in India. We have done few patients, and all these patients I remember were actually very young patients presenting with acute coronary syndromes or ST elevation MIs, where the thrombus load was higher. Once we intervened in those vessels, we found again on the imaging that they had softer lesions, softer some atherosclerotic plaquing, and over which there was a thrombus. And we didn't want to have a metal in their arteries, so we just inflated a drug-coated balloon, kept it for 1.5 minutes, and came out, and vessels looked very pristine after that. So these were our experience of drug-coated balloon with de novo lesions. As I mentioned, we are a center where the coronary imaging is very profusely used. And one interesting more aspect to this is that in all the in-stent restenotic lesions where we used drug-coated balloon, almost all, we used cutting balloon prior, and with a vessel to balloon ratio of 1:1. So this was a very common practice here in our institution. This has been that we use that in all in-stent restenosis patients. So this is there was another slide which tells that almost the patients where we have used the DCB, mostly 70-80% have been diabetic, whether they are presenting with acute coronary syndrome or in-stent restenotic lesions, since diabetic population is very extensive here. I included few interesting case scenarios. I'm not sure. I think for the sake of it, I continue with the case history.
No, you're very good with
So this is a first patient, 74-year-old male patient who had a diabetes mellitus, coronary artery disease, very interesting patient. And this patient had a bypass done 10 years ago, now landed with a crescendo dyspnea and angina, and he actually resides in Dubai. He's an Indian guy. He came from Dubai to get a treatment here, and he was having a severe critical aortic stenosis. So from that perspective, we have been planning a TAVR on this patient. But before the TAVR, now we check the coronary arteries. So look at this. Now this is a post bypass patient. So there is one ramus where the graft is occluded, and a lima to LAD is patent, but there was a stent done at the anastomotic side outside. Now this stent is showing a critical instant restenotic lesion. So in both these cases, since we were planning a TAVR on this patient, we planned that we go with the DCB in both these lesions. One was instant and one was de novo, ramus lesion. So lima was hooked and pre-dilated first with the normal balloons. The wiring was difficult. We could use a Fielder XT wire, and then 1.5 balloon and 2 millimeter balloon expanded, and then 2.5 25 millimeter DC sirolimus eluting DCB there. And we had a very good result. I'll show the results. And this is a ramus, again a DCB to de novo ramus lesion with a sirolimus eluting magic touch 2.5 10 millimeter at 12 atmospheres. Next. So this is the result of the ramus, and this is the result of at the lima anastomotic site after a 2.5 DCB. So then after that, we just accomplished a TAVR in this patient. This is another one, 77-year-old female, again presented with acute chest pain, diabetic again. And this is very interesting case. Now this lady had received our left main bifurcation stenting outside few years back, 2 years back, and now again landed with acute coronary syndrome, diabetic lady. And look at this, there is a restenosis at both the ostium. So both the ostium are again tightly blocked, and there is a tight instant restenosis at LAD ostium as well as Circ ostium. And already bifurcation stenting done. A very good case here as to think of to plan both the ostiums to be dealt with a DCB again. So we did OCT imaging of both the ostium and balloon dilatations. Again, a cutting balloon dilatation as 1:1 ratio to the LAD ostium and the circumflex ostium. And then 3 millimeter of cutting balloon at LAD ostium and 3 millimeter again at the circumflex ostium. And then followed by again a sirolimus eluting drug-coated balloon at both the ostium, followed by a OCT run. So we had a good MSA achieved after this, and we decided to stop here because getting into the stents again will be more complex. Okay, so this is another complex case. One more case I'm going to show as to the Indian perspective. Next slide. Go to the next slide. So this is the final result of this lady. So this is another case. This is the kind of disease we get. The 50-year-old male patient already had a stent in LAD, again landed with acute coronary syndrome. How can I run this? Okay. So look at this. There is a stent. There is an instant restenosis, and there is a fresh lesion proximal to that previous stent. Now this fresh lesion was actually the culprit lesion, but concomitantly there is a tight instant restenosis also. So we did the OCT imaging, and then followed up. We planned that we will stent the fresh lesion, but do the DCB in the stented part, not to have a second layer of stent. So this is a OCT run of a whole segment, but I'll, for the sake of time, I'll skip that. But there was a clear-cut instant tight restenosis and a culprit lesion proximal to the previous stent. Next. So this is a stent coming in at the proximal LAD and a cutting balloon and DCB within the instant restenotic segment, 3x10 cutting balloon at 10 atmospheres, followed by sirolimus eluting balloon, 3x335. We kept it for 2 minutes. Next. And this is the post DCB run. So again, we got a very good result and good MSAs. There was some distal thrombus, and we had again in the unstented segment, we used a very small stent at the distal edge. But the previous stent, which had an in-stent restenotic lesion, we just did the DCB and came out with a very good result. Next. So this is the final result of the LED, and patient did well. He's in a follow-up for almost a year, doing fine, no clinical symptoms. So these were very interesting 3 cases. The take-home message I would show as a last slide. The drug-eluting balloons are very important tools in the present era. The use of DCBs is growing as we are shedding our inhibitions to use in the de novo lesions. That's what I believe right now we're at a stage. And specifically coronary imaging plays a vital role there, where we find that there is a non-calcified and less hostile atherosclerotic lesion. I think DCB is a game for de novo lesions in such subsets. But in hostile, more calcified atherosclerotic de novo lesions, stent is still preferred choice as far as our part is concerned. Thank you.
Well, thank you very much. That was very insightful and great examples of your practice in India. We move swiftly on to our third speaker, and he covers now the US, of course, coming from originally Italy, a protagonist of the field and a pioneer in the field. So global and US clinical experience with DCB. Where are we now? Bernardo Cortese.
Thank you, Andres. So yes, this is a quite peculiar period of my career where I came to the US, where there is a huge and an urgent need for the tool of DCB in a daily practice. I called this presentation, and I named this presentation Global and US, and then in the next one, I put US in parentheses because there is a huge gap between the knowledge and experience on the use of DCB between US and the rest of the globe. We have seen this morning the status in Europe, and we have seen now what our friends are doing in Asia, which is really amazing. So DCB finally entered clearly into the daily practice of our coronary artery disease patients. So far in the US, we have only one, and at least this we have since this year, March 24, indication for the use of DCB, which is ISR. So I'm presenting you a case that we did at UH in Cleveland quite recently. This seems a quite easy procedure. So you go there, you predilate a little bit, then you put a drug, which actually is not the way how you should deal with drug-coated balloon. And I'm showing you why. So we started predilating it, but the balloon did not expand well. You can see it clearly on the left. This was a 2.0 by 15 semi-compliant balloon at high atmosphere. It did not expand well. So we decided to use the laser. But laser did not cross the lesion, so was stuck in the proximal part. This was a 1.4 millimeter catheter. So it was stuck in the proximal part of the ISR. Then we went on with a non-compliant balloon, a larger diameter, 2.5, after putting a highly supportive guide wire, and then we expanded it. But again, the laser was stuck in the proximal part of the previously implanted stent. So there was no chance of advancing it. And then we did the IVUS, which actually also, if you can let it play, please, was stuck into the proximal part of the ISR. So no chances also to, let me see if I can, no chances to advance and to see and to understand, which is very important, the causes for ISR. So we went on increasing the size and the type of devices. Here we use a trio cutting balloon at high atmospheres. We usually hit at atmospheres which are above 16. But still, after trio cutting balloon, we were unable to pass with the laser, and we were unable to pass with the IVUS. So we put a guide extension, and then we went with the IVL. Okay, so this was a quite expensive procedure, I have to say. We delivered a trio IVL catheter, the entire 120 pulses, and this was the result that we got. So if you can let play also the right video, which is showing the IVUS, in the end we were able to do the IVUS. Okay, thank you. We are able to see the IVUS, we are able to see the stent, but if we go to the next slide, I just blocked this frame, which is a specific area of stent under expansion. It was very short, 1 or 2 millimeters, but that was probably the cause for the in-stent restenosis. So we had to address that, and we tried to address it with a photodilatation, trio non-compliant this time at very high pressure, 24 atmospheres, and then in the end we use a drug-coated balloon, paclitaxel-coated balloon, a trio by 20, and this was the final result, which was pretty good. But the key message of this case is that you don't have only to rely on the angiography on your eyes, also when you have to deal with ISR. We have seen from many studies that ISR is really, I have to say, it's not the most fascinating indication for DCB for me, but it's one of the most tricky causes for reoccurrences of events. And if you don't deal with that, if you don't prepare the lesion, if you don't understand the lesion with intravascular imaging correctly, you are going to fail. And it's better if you put a stent, another stent, stent in stent. But let's go ahead. Which is the status of DCB in the US? They told me I couldn't put the brand name, so so far we have 4 DCB, 2 paclitaxel, 2 sirolimus-coated balloon, which have obtained the IDE for conducting clinical trials. Only one has an ISR indication, but 4 of them, they are all pursuing the de novo indication, which, as I said before, is one of the most important and fascinating indication for the use of DCB. But so far, we can use DCB only for ISR. So the experience is very limited. I would say around 1% of the PCIs, not available in all of the centers, very expensive. Reimbursement will come, and it should come in January 25. But so far, there is no reimbursement for outpatient and inpatients. Some centers are using DCB for high bleeding risk patients, but this is a completely out-of-label indication so far in the US. And again, not only not reimbursed, but also completely off-label. So in the meantime, what's happening in the rest of the world? Because, luckily, I still have the chance of going away and conducting with my foundation clinical trials with approved drug-coated balloons. Andromeda is a meta-analysis, which is very important to us. First of all, because it collected among the most experienced operators on DCB in Europe. And the importance of this meta-analysis, which has been accepted for publication in the European Heart Journal 2 days ago, is that for the first time on the long term, in a small vessel disease below 3 millimeters, we have shown a reduction in the MACE with drug-coated balloons as compared to drug-eluting stent. And this derives from an adequately powered patient-level meta-analysis of 1,500 patients, collecting all the data of the randomized clinical trials in de novo lesions. And then the other big question is, what is better? Is it better paclitaxel or sirolimus? But first of all, we all know that there is no class effect. So also within sirolimus and within paclitaxel, we cannot claim there is a class effect. We wanted to dig a little bit deeper into the differences among seven types of different drug-coated balloons with this Picoleto 6 study, which has been presented at TCT this year for the final assessment. This is an independent study sponsored by Fondazione RIC with an independent core lab, which aimed to see in a multi-center design, which is the difference in terms of physiology. Because what we know so far is that paclitaxel is definitely better than sirolimus in terms of angiographic parameters. If we do angiographic follow-up, paclitaxel is better. in almost all of the studies, there was either a trend or a significant superiority for angiographic parameters. What we wanted to understand with Picoletto 6 is if there is a difference in terms of function, activity of the DCB, and we developed this new endpoint, which is the late functional loss, so the difference between final physiological assessment and follow-up physiological assessment of all of these DCBs. And for this specific trial, we expected the non-inferiority, which was calculated according to the only published study, which is Picoletto 2 mu-FR, which has been published on CCI, addressing the efficacy of a paclitaxel-coated balloon in terms of late functional loss. Which are the main information that are coming from Picoletto 6? First of all, this is a real-world study in de novo lesions. The lesion length is double than the one of Transform 1, double than the one of Picoletto 2 and of Bello studies. It's 24 millimeters. This is a real-world study with diffuse disease in 40% of the cases. The big information that we have, which is not surprising, is that paclitaxel did outperform sirolimus in terms of late lumen loss, which was pretty good also with sirolimus, was 0.10 millimeters in this small vessel disease study, but it was negative with the paclitaxel, minus 0.5. And then coming to the primary endpoint of the study and the physiological assessment, mu-FR was 0.87 in the paclitaxel, 0.85 in the sirolimus-coated balloon after 4 to 7 month angiographic follow-up. And there was no differences in terms of the primary endpoint of late functional loss between paclitaxel and sirolimus. So physiologically, these two classes of devices did not perform differently in Picoletto 6. And now let me finish my presentation with a real world. As I was saying, I'm lucky because I have the chance of proctoring a lot around the globe. This is a European case that we did with the diffuse disease, no ISR, de novo lesions with the DCB. So this is a 71-year-old hybrid in Greece lady that we decided to address with this Ramus and this LAD. So the decision if to use a DCB should be taken only after lesion preparation. So prepare the lesion with a semi-compliant 2.0 by 20 in the Ramus, then we use a sirolimus-coated balloon 2.5 by 25, obtaining this result. It's a nice dissection, not a flow-limiting one, which is good if you wait a little bit and you see that you don't have recoil or any flow impairment. Then we started preparing the LED, and specifically we used a semi-compliant balloon 2.5 by 17. You can see that on the left that we predilated the distal part, we predilated the mid part and the proximal part, and also the ostium of the LED with a 275 by 17. You don't have to be harsh here. You don't have to implant a stent if you prepare the lesion correctly and you are not dealing with a severe calcification. So that could be enough, but only after the angiographic assessment, after lesion preparation, you can decide if to use a drug-coated balloon here. And here I have to say that we were pretty happy of the preparation of the lesion. So we decided to deliver the drug, which we did, but we did only in the proximal and in the mid part of the LAD. We use a sirolimus-coated balloon again, a 275 by 25 in the ostial LAD, a 2.5 by 25 in the proximal LAD, and we left the distal part with POBA. And this is the final result after our angioplasty with this type C, BC, whatever, dissection in the ramus, good flow again, no recoil after 20 minutes, and quite the same, pretty good result in the LAD. No stent-like, but that's enough for the drug to penetrate, in this case, Limus drug. We also have a graphic follow-up for this patient, which is pretty good. After 4 months, the colleagues sent me this result, which is showing how the result in the ramus is very good, dissection healed, in the ostial LAD, very good, or LAD, very good, proximal LAD, mid LAD, good, but with some restenosis in the distal part of the LAD, where we had used a POBA and not a drug-coated balloon. And a glimpse into the future. So there are several clinical trials that are ongoing. One of them is the one that we are performing globally from Brazil to Malaysia and Brunei, which is Transform 2. Now we are comparing drug-coated balloons to drug-eluting stent. This is the need that we have. We have some data. We may discuss about that with the REC cage-free, but Transform 2 is randomizing patients after lesion preparation to an everolimus-eluting stent and a sirolimus coated balloon for de novo lesions, not only in small vessels, because we are including lesions with vessel size between 2.0 and 3.5 and lesion length up to 50 millimeters. So far, we have enrolled 1,300 patients out of the 1,800. So hopefully in the next 4 to 5 months, we will be able to end up with the enrollment of this pivotal trial and see if finally we will have an important answer in terms of a non-inferiority for a clinical endpoint between a drug-coated balloon and a drug-eluting stent in the de novo setting. Thank you for your attention.
Excellent, Bernardo. As always, you've answered all my questions in your slides before I could even ask them. I've got some points we should go through, and you mentioned some of it. I'm going into clinical routine now. Dr. Kapoor in India, Rajneesh, we make an emphasis to say we need to prepare the lesion optimally. What do you tell your trainees? I mean, I'm sure you train them in the use of DCB. What do you actually tell them? Do they have to use a cutting balloon? Do they have to use IVUS?
So yes, so definitely as a practice here, we use this, that we now are using more imaging first to understand the characteristics of the lesion, and based on that we decide. So our cutting balloon usage to prepare the lesion before we decide anything, stent or DCB, is very prevalent here, and we use that quite often, or at least the scoring balloons. If on imaging we find it's a hostile lesion, there is some amount of calcium, then more commonly we stick to cutting balloon and then go ahead. But in stenting, if we have already decided to stent the lesion, we do the pre-dilatation with semi-compliant balloon, go ahead with stent, and then aggressively post-dilate. And usually our imaging usage is 70 to 80%. But in case we are planning a DCB or drug-eluting stent based on the bed preparation, then we definitely are thinking more aggressively with the usage of scoring balloons and cutting balloon for preparation of the lesion. And if it is too calcified, then obviously IVL or some decalcified maneuvers have to be used prior before we really stick to that, any further intervention. So, but yes, after the bed preparation, if we find the lesion is very well prepared, in those cases we can think of restricting ourselves to DCB. But if there is still a recoil and still calcium nodules are still existent there and not doing very great, after which we come across, we actually see the balloon dilatation in two orthogonal views. If it is still not inflating well, then obviously we go towards a more stent usage.
Thank you. Rosalie, more or less the same question. So with drug-coated balloons, we're going back to balloon angioplasty, which has dissections, which has recoil, everything we thought we got rid of with stent implantation. Now we're back. So what is an acceptable result for you? You have a vast experience, obviously, with these devices, and you want to sleep. I think we get that as a title. So, what is an acceptable result for you?
I think, as you said, the recommendation suggests that for de novo lesion, and this is where the money is, de novo lesion, you should, prepare vessel 1:1, balloon to artery ratio, and then look at the results. There may be dissection, but you should not fear all dissections. As long as the flow is good, and then the residual stenosis is less than 30%, you're good to go for DCB. But you find that, and this is where we have been so used to stenting. Stents are very fast, quick, and you end. But the long-term effects may not be as good because of stent failure. But with DCB, you got to be patient. You prepare the vessel, especially if you see that there's a dissection, you may want to wait for a while. Just wait for a while to see that the dissection doesn't progress, and then it doesn't progress, and as we said just now, the criteria, then use DCB. Mm-hmm. It is not going to be good for you to use prepare vessel, use DCB, and then you've got to convert to a stent. That really demoralizes the use of DCB. So it is very pertinent, important. Vessel preparation is good, and then you decide if it's safe to use a DCB. If it's not, then use DES. So that's my advice.
That's the true hybrid approach. Bernardo, in all the protocols and in your clinical practice before you came to the US, where it's only in-stent restenosis, what is the follow-up protocol? What's the antiplatelet treatment protocol that you are using? We had everything from 2 weeks to 3 months this morning. I don't think there is a rule. So what are you using in clinical practice if you manage to do a DCB only?
So in terms of follow-up for antiplatelets, I think that this is also an area where DCB is particularly fascinating. If we take a look to the clinical trials with drug-eluting stents dealing with the short DAPT, Onyx 1 or the 28 days for Zions or whatever, we can see that anyhow, either you go with a prolonged DAPT or a short one, you have an impaired outcome in the DES patients. With DCB, we have done a retrospective study, and now we are running the Piccoletto 4 trial, which I did not have the time to present earlier, which is randomizing patients, elderly patients or high bleeding risk patients, to single antiplatelet therapy versus DAPT. So, which is the current practice? So far, the current practice is we go for de novo, no other stents in other arteries, 1 month is enough. For ISR, you can go between 1 to 3 months according to the risk profile of the patient and the final result. But if you have a high bleeding risk patient, pending the results of our randomized clinical trials and another one which is run by Thomas Rissanen, is that we can go also with single antiplatelet therapy if there is a real clinical need. And this is very important, because we have to remind that we invented the second antiplatelet back in the 90s because of the high thrombotic risk of the first generation bare metal stents. Then we decided that for DES, maybe we needed more, polymer, no polymer, whatever. But all of this is related to the metal. In the POBA era, we didn't need a second antiplatelet, which is quite the same for drug-coated balloons, because if they have limitations, they don't have the limitations with any drug to be thrombogenic if you have done a good job.
It's really, really good you remind us of the 90s, where we did local drug delivery and plain old balloon angioplasty. And it's good to have this experience still around, because it is important and relevant for this technology, drug-coated balloons.
I was not there, but Andreas, I have to say, not at all.
Yeah, I was. Rosalie,
yes.
It falls to you to close this series with a case in point. So over to you, a typical case of your practice.
Right. Thank you very much. So I think one of the main concerns of using DCB during PCI is the fear of dissection. And that's why the stents are being formulated. And once stents are there, everyone says they would want to use a stent. And the question that you always, the word that has always been spoken is that I just want to make sure I sleep well at night. It doesn't necessarily have to be so, because of course, Cortesi is still young, but the use of POBA in the past, where you inflate for a long time, you tack up any dissections, and after a long, balloon inflation, you might actually get away with just, balloon dilatation. But this is just an example of the diffuse disease in the LED and also the diagonal. And the plan then was to actually treat as vessel preparation and treat as much as possible with DCB. But unfortunately, what actually happened is that after balloon dilatation, there was dissection, I lost the position of my LED wire. And I could not really get into the true lumen at any point with the use of a lot of other devices. In the end, I decided to stop. And the reason is I said, if I were to go again and again, it will cause hematoma, spiral dissection, and I would lose the vessel. So I decided to stop. And at the end, the flow was at least 2 to 3. And the patient was quite stable. I brought the patient back after 5 weeks. And the vessel, that section has actually healed. The flow is still very good. And this allowed me to continue and treat this patient. So this is just to understand that we need to not fear all dissections. We need to know and learn regarding dissections, like what we did in the past, to identify that there are certain dissections that will not cause abrupt closure. It's understanding this. Because any dissections that will close or collapse the vessel, cause abrupt closure, that is where the lesions need to be stented. And this is something that we need to learn. So coming to that, I've got a patient that I just want to share with you. Let me see whether I can go this. Yeah, a 47-year-old man. Actually, he's also diabetic that was diagnosed at the point that he was presenting with acute anteroseptal STEMI. And he was referred to us for a procedure because the angiogram showed that the vessel was occluded, and there was, the physician thought that we should, treat the lesion. There was also a severe stenosis in a large D1 and D2. D3 was actually very small. So this was done in 2020, and we managed to cross. It's fairly easy to cross soft lesion. We pre-dilated with 2.5 mm balloon, and that was the results post-POBA. And we said, hey, this is a chance that we may actually use drug-coated balloon. But the lesion was still not well prepared. So you can see that in the mid-segment and the proximal segment, there was still a significant residual stenosis. So in this case, we took to prepare the vessel by using a Wolverine cutting balloon, a 3.0 mm, and that was the results after. We find that by the use of specialty balloon, scoring, and also cutting balloon, we tend to get fairly good results. And from that results post-cutting balloon, we felt that this is a lesion that we can treat with drug-coated balloon. So we used 2 long drug-coated balloons, 3.0 by 40, 3.5 by 30, and that was the results after. We then went on to treat the drug-coated, the diagonal 2 and 1 branch with, once again, cutting balloon, 2.5 mm, and then treated with a 2.5 mm in the D2 and 3.0 mm in D3 and D1. We left the D3 alone because it was small. And that was results post-DCB. Once again, this is a flow image. You can see that there are some dissections in the mid-LED, but the dissection is only probably type 1 or type A and B. And what is important is the flow. Now, I just put up the number of time that we did and waited. And you can see that 10 minutes, 19 minutes. And this is the point that I was trying to make, that you need to be patient if you are not certain whether you need to stent or otherwise. So I find that if, let's say, after 5 to 10 minutes, the flow is still very good, the dissection hasn't progressed, this vessel will not close. And that has been our experience. And that's the final shot. And we brought this patient back to be restudied 16 months later. And you can see that the lesion on the right side, 16 months, is still very good. And in fact, the vessel has actually grown a bit. And that was another view to show that the vessel has healed and the vessel has actually grown in some parts. This is the index procedure, the section that you can see, and in the 16 months restudy. All right. So I believe once again that we need to understand that the key to successful DCB treatment depends so much on lesion preparation. And secondly is that we must also always remember that DCB is to deliver the drug. It is not to relieve stenosis. like balloon angioplasty. So I've seen people using DCB and using it at 14 atmospheres and so on. This is not the way. Prepare the vessel first and then use DCB. But it is important for us that if you want to use DCB, you have to gain this confidence. You have to ensure you understand the dissection, get good results, and then your confidence rise and you will be using it in more and more patients. So to summarize the indication of DCB, to me, ISR is ideal because you don't want to place another second layer of stents, and it's guideline supported. I believe hybrid therapy is probably the way to go because this is being practical. A lot of people has got good experience DS, especially in the proximal lesion, that they want to use it DS. And in other segments, like for example, long diffuse lesion, small vessels, and side branch, for example, this is where they would want to avoid stenting, and DCB is a good alternative. But for people who believe in DCB treatment, and it is potentially possible, you just need to ensure that you get good results with vessel preparation, and that is a matter of conviction and commitment, and then you will be using more DCBs in your practice. So I would like to thank you once again. Do join us in Asia PCR in Singapore in October of 2025. Thank you once again. Thanks, Andres.
For that plug. Rosalie, thank you. I've got one direct question, then one more for Bernardo from the audience. Just because you brought the patient back, is it routine in your practice to bring patients back for angiographic relook? And the reason I'm asking, how often do you see an enlargement of the vessel, which is clearly something good, right?
All right. Firstly, enlargement vessel, I see it's quite common. Kleber showed in his first paper vessel enlargement in about 70% of patients. Paclitaxel has slightly better than sirolimus, but both drug has shown some vessel enlargement. Now, do I stay there routinely? In the beginning, when I started to do more complex lesion, I do. I just need to understand it, especially when there's dissection, long lesions. I just want to see how it goes. And once I've done this, then and I understand, how the results, relate to your long-term results, relate to your immediate post-index, then I grew more confident, and I don't really study all lesions. Okay. Nowadays, it's not common.
I thought so. We've got two questions left from Ahmed and George Kikeno. First one to Bernardo. In the case of paclitaxel DCB failure for treatment in stent restenosis, would you prefer using a limus DCB or another paclitaxel DCB for managing the recurrence? That's clearly a practical question. So do we swap? Do we believe there is a difference? Quick answer.
For a stent, I would say it's not forbidden by the law. We have seen the data from the Lumion 4, the sub-analysis, which is showing after OCT usage, if you put another stent, it's going to work well. You have a TLF of 8% at 1 year, which is very good. Well, less than that, maybe 7. So the thing is, if you have a failure after ISR treated with a drug-coated balloon, it's not a matter, I would say 90% of the cases, it's not a matter of the drug, but it's a matter of the fact that you have probably not addressed the cause for ISR. So use imaging, you use it better, use the lesion, a different lesion preparation, and then in the end you can reuse paclitaxel or use sirolimus, whatever, or use a DS. But what is important is what you do before.
Excellent. And the last one is really, is the use of ISLGT2 and GLP-1 analogs required to improve results of these new devices, even in non-diabetic patients? I think we don't have much data, but
no.
I'm not sure there's harm. So I think we're coming to the end of this episode and the series, really. Again, we have 3 others that will be online and ready to be viewed. I think we made it very clear that globally DCBs are not a niche anymore, and they are certainly also not just research anymore. They are part of standard care in more and more in a hybrid fashion together with stents as needed, not exclusive. We have learned if you do it, you have to do it well. There's a learning curve certainly, and there is a need to teach. We also learned that we need more evidence, and that is coming. And I hope that the examples by our leading experts and enthusiasts, I might say, were helpful and informative. And I hope you enjoyed these episodes. With that, I say goodbye. Thank you.
Thank you.
And
Thank you. Thank you.
Thank you. Bye.
Bye.